Hello guys and welcome back to Count to 10. My name is Ani and on today's episode we're going to be covering the last episode in our series, Neurophysiology and Pain, and our topic today is pain physiology. Now this is a topic, when I think about it, my immediate response is one of dread, and I feel this because it's a topic that has so many important concepts and important definitions that it's really hard to get a good grasp on initially, and there's a lot of learning objectives that are just chucked in here that don't really fit in anywhere else, making this a very long topic as well. This episode has the potential to be one of the longest episodes that I've recorded so far. There's a lot of things that we're going to cover, but hopefully I'm going to break it down in a stepwise approach so that you guys don't feel as scared of this topic as I did when I was first covering it. This is a topic that classically has SAQs with a very low pass mark, but the good feature is there's not too many SAQs that come from this topic. Hopefully by the end of this episode, you'll have a good building block and a fundamental base for understanding pain physiology. I'll try to cover the broad concepts as well as some of the minutiae without going too much in detail, and there's a lot of concepts that will hopefully overlap with our previous episodes on our topics of neurophysiology and pain. So with that said, let's dive straight into it.
1, 2, 3, 4.
The first and the objective we're going to cover today is describe the anatomy of the sensory pathways with particular reference to pain sensation. Now this LO actually flows on quite nicely from our last episode where we talked about spinal cord anatomy. Now we know that the spinal cord extends from the medulla oblongata and exits out the foramen magnum. It ends at L1, L2 in adults and roughly L3 in neonates. Where it begins to end, it tapers off, and that tapering is known as the conus medullaris. Once the tapering occurs, below the level of L1, L2, there's still nerve roots from the lumbar and sacral region, and this makes the cauda equina. There are in total 31 segments of the spinal cord, each in pairs, exiting out of the intervertebral foramen, except for C1 and C2, and when you take a cross-section of the spinal cord, what you see is a combination of grey matter and white matter. The grey matter makes a classic H shape, and this is an important shape to remember when we talk later about second-order neurons and a classification known as the Rex laminar classification, which divides this cross-section into different areas. But the reason the grey matter is important is because this is where the processor of incoming signals occurs and is the main relay station for these signals. The grey matter is the unmyelinated nerve fibers, while the white matter is the myelinated axons, and the white matter is what creates the tracks that can either be ascending up to the brain or descending down to the peripheral body. Now the important landmarks to know on this cross-section of the spinal cord is understanding that the afferent signals come through the dorsal root while the efferent signals go out of the ventral root to the effector regions. So in terms of the sensory pathway, there are really 4 important steps to know of in this pathway. The first step is the stimulus. The second is the sensory receptors themselves. The third is the afferent sensory neurons. And then the fourth is the central sensory pathways in the brain or to the brain. When we look at the first step in this pathway, being the stimulus, this can be any sensory signal which is analysed from outside the body and then taken into the inside of the body. The way it's taken in is through the second step, which is the sensory receptors. There are many sensory receptors throughout the body, and you can classify them in a couple of different ways. The first way you can classify them is by location, and there's 3 classic locations where the sensory receptors exist. The first being the superficial somatic receptors, and these are mainly on the body surface or mucosa and deal with things like touch, pain, and temperature. The second are the deep somatic or proprioceptive receptors that are normally in muscles, joints, or tendons, which are involved in the sensory pathway for stretch and movement. And then finally, you have visceral receptors that are located within the internal organs. The other way to classify sensory receptors is by the type of sensory receptors that they are. There's 3 overarching types of sensory receptors that exist. The first are mechanoreceptors, of which there's 4 types, and these are the receptors that are known as your Pacinian, your Meissner, your Ruffini, and your Merkel, and they're doing a combination of things such as recognizing pressure, vibration, light touch. Then we have the second class being the thermoreceptors, and thermoreceptors are specialized receptors that come from free nerve endings of either A delta cells or C fiber cells. Then finally you have the third class, which is the most important for us today, and these are the pain receptors, i.e. the nociceptors. Broadly speaking, they can be broken up into 2 groups, the C polymodal and the A mechanoheat receptors. The C polymodal recognize stimuli that can either be thermal, mechanical, or uniquely to them, chemical, and the way you remember that is C stands for chemical, while the A mechanoheat receptors recognize either thermal or mechanical stimulus only, and that's why they're named this way. We'll talk a lot more about these type of receptors in the next learning objective, but this is the broad classification of your sensory receptors in your sensory pathway. Then our third step in our sensory pathway is the afferent sensory neurons. When you think about the afferent pathway, think about that classic photo of someone having a painful stimuli at the thumb and that stimuli being transmitted from the thumb all the way to the spinal cord and then to the brain. The neurons that are transmitting this information are the afferent sensory neurons, and we classify these by calling them either first order neurons, and as the name sounds, these are the primary afferent neurons that carry the signal all the way to the dorsal root ganglion, where you have the second order neurons, which receive the primary afferent input and then synapse all the way up to the thalamus, which is your main relay center, where you have third order neurons, which relay signal to different regions of the cerebral cortex. And then you can also have fourth order neurons, which are located across the sensory cortex, where you might have specific areas for processing that sensory stimulus. Now, in terms of the ascending sensory spinal pathway, so this is the second order neurons, there's 3 main pathways that you need to know of. The first major pathway is the dorsal column medial lemniscus pathway, and we touched on this when we talked about posterior cord syndrome in our last episode. This is the pathway which carries information about fine touch, vibration, proprioception, and 2-point discrimination. These are large myelinated A-beta fibers within the cell body of the dorsal root ganglion, which ascend ipsilaterally and then at the medulla cross over, aka decussate, onto the other side, and then ascend on the contralateral side to the thalamus, where then they get relayed by the third and fourth order neurons. The second main ascending pathway is the anterolateral pathway, also known as our spinothalamic tract. The reason it's called this is because you have an anterior portion and a lateral portion of your spinothalamic tract. The function of this is to transmit crude pressure, temperature, and pain stimuli. In contrast to the dorsal column medial lemniscus pathway, which travel ipsilaterally until they decussate at the medulla, what happens with the spinothalamic tract is that they cross over straight away when they enter the spinal cord. The other unique thing with this pathway is that the first order neurons can either go up or below the level at which they enter the spinal cord, and this occurs through a unique tract called the Lesueur's tract. This is a really important concept to understand because it plays into why pain at one dermatome level might be felt at multiple dermatome levels. Because of that sensory pathway either ascending 1 or 2 levels or descending 1 or 2 levels. Once the nerve fibers cross over, this tract then travels ipsilaterally all the way onto its second and third order neurons. The nerve fibers in our spinothalamic tract are our classic A delta myelinated fibers or our unmyelinated C fibers. The final ascending sensory pathway is our spinocerebellar tract. The function of this tract is to relay important proprioceptive information carried by our A alpha fibers, therefore our fastest fibers in our body. This tract just travels ipsilaterally without crossing over at all, And the reason I'm stressing the importance of knowing which tracts cross over and which tracts do not is because it has important clinical value. The classic Brown-Séquard syndrome, where you get injury at the spinal cord at any particular level, and below that level, you know that the dorsal cord is affected ipsilaterally, while the spinothalamic tract is affected contralaterally. So clinically, you see the loss of fine touch vibration on the same side of the injury, but the loss of pain and temperature on the contralateral side of the injury. Then going back to our sensory pathway, the final step in our sensory pathway is the central sensory pathway in the brain. The main region is our somatosensory cortex, and this is when you go back to med school, you would have seen the homunculus, which shows what part of our cortex receives specific information from different body parts. Now that's a broad overview of the sensory pathway, and we'll focus more about how this relates to pain sensation in our next learning objective. Just briefly, this LO doesn't ask about the descending motor pathways, but it's important to know that there's two overarching descending motor pathways. These are either your pyramidal tracts or your extrapyramidal tracts. And the way I think about that is that your pyramidal tracts are the ones that are involved in mainly your voluntary movement and control of your skeletal muscle, while your extrapyramidal tracts kind of do all the things you need to do without you having to think about it. So these are things like maintaining posture, tone, and sometimes this tract is also needed to help direct voluntary movement as well. This moves us nicely to our next learning objective, which is a really big one in this topic, and that is describe the basic physiological mechanisms of pain, including peripheral nociception, conduction, spinal cord modulation, central processing of pain, mediators, pathways and reflexes, peripheral and central sensitization, preemptive and preventative analgesia. The first time I looked at this learning objective, I was definitely overwhelmed, but all this LO is asking you is to look at the sensory pathway we've just discussed in our previous learning objective, but put more of a pain lens on it. In doing so, you can divide this LO into 4 key terms. Understanding that pain needs to be transduced, i.e. the stimulus needs to be converted in some kind of way. The pain then needs to be transmitted, i.e. through our sensory neurons, being our first order and second order neurons. There needs to be then some kind of perception of the pain, so what happens in the brain, followed by some kind of modulation that helps to decrease that initial pain stimuli. And if you can divide it into those chunks, this LO then becomes a lot more manageable and much easier to conceptualize when you're breaking it down. Now, starting off at the very beginning, looking at how we define pain, pain can be defined by the International Association for the Study of Pain, known as the IASP. This definition changes every 2 to 3 years, but the most recent update is that it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. It's a complex definition, but in simple terms in my brain, what I describe pain as is that it's a combination of sensory, emotional, and behavioral factors. Everyone experiences pain uniquely. You don't need to have damage to your body to have pain. You can have pain even without damage because of that emotional and behavioral component to it. However, for our understanding, if we think about pain as that classical getting injured and having a noxious stimuli, this will help us to better understand the pain pathway, starting off at the nociceptors. We said that the nociceptors were the pain receptors, and there's different types of nociceptors. They can either be C polymodal or A mechanoheat receptors, but they can also be classified by the structure of their receptors. Nociceptors can either be ion channels, they can be G protein coupled receptors, they can be neurotropin receptors, or they can be something that's even called silent nociceptors. There are many different types of ion channel nociceptors, and these involve our transient receptor potential family, so our TRP family, our sodium channels, our potassium channels, our acid sensing ion channels, our voltage-dependent calcium channels, our purinergic receptors, and our serotonin receptors. Now, no, you don't have to remember all the different types of receptors, but you just have to know that nociceptors can take the form of multiple different structures. The important thing you have to know is that the stimulus that they respond to can either be thermal, mechanical, or chemical. Now, it normally takes a lot of stimuli to activate a nociceptor, and that makes sense. If you touch your hand right now, you're not in pain. But if you pinch your finger really hard, that's when you start to experience pain. So nociceptors classically have a very high threshold to then be activated. Once these receptors are activated, you need to have that transmission of the signal, i.e. the conduction through the primary afferent fibers. The two afferent fibers that conduct pain are either going to be your A delta fibers or your C fibers. Classically, your A delta fibers will conduct pain, which is rapid, well localized, and sharp, being more consistent with somatic pain, while your C fibers will conduct pain which is poorly localized, slow and dull, and has a prolonged effect. Visceral pain is normally conducted through the C fibers, and these C fibers piggyback onto the sympathetic nervous system fibers. That is why when you feel pain, you also get that tachycardia and that increase in blood pressure, and pain isn't just a single response in your body. It leads to a multitude of responses which lead to an unbalancing of our normal homeostatic mechanisms. Once the A delta and the C fibers have carried the information to the spinal cord, you now need the second order neurons to then continue that transmission up to the brain. Where the primary afferent fibers finish and the second order neurons start is within the dorsal horn of the spinal cord. Remember earlier we spoke about the cross section of the spinal cord, and we said that we could divide the spinal cord into different sections known as rex lamina. Essentially, the way this works is that you divide the spinal cord into 10 sections, and the most important section to remember is section 2, known as our substantia gelatinosa, because this is where principally our C fibers terminate. Our A delta fibers normally terminate within rex lamina 1 or rex lamina 5. And the reason I bring this up is because sometimes this is asked as an MCQ. Now, at any junction where one neuron ends and another neuron starts, there needs to be a transmission of signal that occurs through the release of neurotransmitters, and then they bind on to subsequent receptors on that postsynaptic neuron. The different types of receptors that can exist in the spinal cord are a combination of receptors that will respond exclusively to noxious stimuli, being our nociceptive specific receptors, a combination of low threshold receptors, which will slowly respond to stimuli, and then importantly, a type of receptor known as a wide dynamic range receptor. This responds to not only noxious stimuli, but non-noxious stimuli, and is thought to be an important player in the process of sensitization. Normally, these receptors do not signal pain. However, if there's repeated discharge and repeated activation of these receptors, then they can start to relay the signals of pain, and what was previously a non-noxious stimuli can then be perceived as pain, known as allodynia. Now, not only do you have these types of receptors, you also have lots of receptors in this area presynaptically as well. This is a really complex area that's not only important in transmitting the signal of pain, but also blocking the transmission of pain, i.e. the normal analgesia processes that we have in our body. Within this area, you can find receptors such as opioid receptors, which are majority presynaptically 75% and postsynaptically 25%, and as you know, the activation of these will lead to a decrease in pain. You can have NMDA receptors, which are important in transmission of pain and the development of things such as chronic pain. You can have cholecystokinin receptors, or our CCK receptors, which can play an important role in the development of neuropathic pain. And you can have GABA receptors, also located in this area. With these multiple types of receptors, it's natural to think that there'll be lots of neurotransmitters also in this area. And the neurotransmitters can be grouped as non-peptide neurotransmitters like glutamate and GABA, peptide neurotransmitters like substance P, bradykinin, enkephalins, and other neurotransmitters like adenosine, capsaicin, cannabinoids. So this area plays a really important role not only in our pain transmission, but also in our pain modulation. And we'll talk a lot more about this when we get to talking about peripheral and central sensitization. To complete the pathway of pain going up from the second order neurons to the third order neurons, you need to understand the different pathways that can conduct that pain. We've touched on what the main tract is, being the spinothalamic tract, but this is not the only tract that relays pain up to our brain. Other tracts exist known as our spinoreticcular tract, our spinomesencephalic tract, and our spinolimbic tract. And you don't have to remember all of these, but what this tells you is that the transmission of pain is complex and it involves processes that lead to us having anxiety, the autonomic changes that occur with pain. All these different pathways are being activated when we have a painful response. And this is why we say that pain is a complex topic to understand. For your learning, it's just important to recognize that the spinothalamic tract isn't the only tract which is important in relaying the information of pain. From this, when we finally get to the central processing of pain within the brain, there are a lot of areas in the brain which are important in localizing and sensing pain. The primary somatosensory cortex is key in pain localization, but you also have a secondary somatosensory cortex, which is important in understanding pain intensity and the spatial appearance of pain. You have the insula, which complements the secondary somatosensory cortex in understanding the pain intensity. You have the anterior cingulate, which is responsible in the emotional regulation or the emotional aspect of pain. And then you have the prefrontal cortex, which is important in how we memorize pain and our pain modulation. And the easiest way to sum up all these areas is to say that within the brain, you have a pain matrix. This then leads us on to how we modulate pain through our descending inhibitory pathways. And there's really three important areas in our brain that help that descending modulation. These areas are the paraqueductal gray, the nucleus raphe magnus, and the locus coeruleus. Starting off with the paraqueductal gray, this is located near the cerebral aqueduct in the brain, and it receives inputs from the thalamus, the hypothalamus, the cortex, and the spinothalamic tract. The end result is that there's a release of endorphins into the CSF and blood, which help to exhibit an inhibitory effect on several centers throughout the brain. This is intrinsically linked to the nucleus raphe magnus, which is located in the medulla, and this has axons that can directly synapse into that rex lamina 2, that substantia gelatinosa, where it can release mainly serotonin that will inhibit the ascending pain signals. Then you have the locus coeruleus, which is located in the pons and descends and does the same thing that the nucleus raphe magnus does and release neurotransmitters that help to decrease that ascending pathway. The principal neurotransmitter it releases is noradrenaline. And clinically, we can modulate the effects of the locus coeruleus using drugs like clonidine, which are alpha-2 agonists, that then change the concentration of noradrenaline to help produce a centrally acting mechanism for pain relief. So these are our three main descending inhibitory pathways: the paraqueductal gray, the nucleus raphe magnus, and the locus coeruleus. Now we'll move on and talk about one of the most important concepts in this learning objective, which is talking about peripheral and central sensitization. Before we look into these two terms, there's some important definitions you need to know of. The first important definition is understanding the term hyperalgesia. This is increased sensitivity to a noxious stimuli. The second term is allodynia, which is pain evoked by previously stimuli that was non-noxious, i.e., you get pain from something that wasn't painful before. The third definition is primary hyperalgesia. This describes an increased sensitivity within the area of injury and is produced by the changes in the peripheral nociceptors themselves. while secondary hyperalgesia relates to undamaged skin around the injury site and is due to a centrally mediated change. What that relates to is the importance of those wide dynamic range receptors that we spoke about earlier. To further help me conceptualize these definitions, I link the terms hyperalgesia and primary hyperalgesia with primary sensitization, while allodynia and secondary hyperalgesia more so with central sensitization. So what is peripheral sensitization? The key thing I want you to remember whenever someone says peripheral sensitization is remember the term inflammatory soup. Peripheral sensitization refers to the process which is occurring at the site of injury, so where those nociceptors are. What it's describing, through repeated activation, you're either getting a decrease in the threshold or an increase in efficacy of the transduction and the transmission of the pain from when those nociceptors are activated. The reason this occurs is when you get that activation of the nociceptors, you get that release of all those neurotransmitters we spoke about. These involve things like endothelin, prostaglandin, bradykinin, leukotrienes, cytokines, adenosine, potassium, lactate. All of these things are inflammatory mediators which are creating that so-called inflammatory soup that is changing the gene expression and the protein synthesis of those nociceptors. This is why when we look at risk factors for people to go from acute pain to chronic pain, the biggest risk factor is acute pain, and why we try to actively and aggressively treat acute pain before it becomes chronic pain. In contrast, central sensitization is the process which is occurring mainly in the spinal cord. And the way I think about central sensitization is that it's a process that takes time to occur and intense noxious stimuli and tissue damage to eventually get to that state. However, the steps needed to get to that end stage start to occur as soon as you get acute pain. So while it's a process that takes time, it's a process that's occurring slowly as soon as you get that painful stimuli. And this is what manifests as spread of the sensitivity of the injured site, i.e. secondary hyperalgesia, and a generation of pain at low threshold stimuli, i.e. allodynia. The key terms with central sensitization are wind-up phenomenon and long-term potentiation. So with peripheral sensitization, think inflammatory soup, and with central sensitization, think wind-up and long-term potentiation. Wind-up describes what it sounds like. It's when repeated stimuli with no change in strength cause an increase in response from the dorsal horn neurons mediated by the release of excitatory neuromediators. The most important is our NMDA receptor, and this is why you see people using agents like ketamine for patients that have chronic pain. The important neurons in this response are our wide dynamic range neurons. Remember, those are the ones that respond to mainly non-noxious stimuli, but if you keep activating them, they'll also respond to noxious stimuli. The proposed mechanism for wind-up is that the repeated stimuli of those second-order neurons primes the NMDA receptors, removing the magnesium plug, which is key at blocking the NMDA receptors from being activated in the first place. These primed NMDA receptors now require less stimulation to activate the second-order neurons, and the activation of the second-order neurons causes transmission of the nociception, altered gene expression, increased expression of the NMDA receptors, and stimulation of those wide dynamic range neurons, which causes that secondary hyperalgesia and allodynia. As these processes alter gene expression, what's happening is a process called synaptic reinforcement, which is leading to our long-term potentiation. So there's long-term changes that are going to be reinforced within these receptors and neurons, leading to that patient having that chronic pain. And just to reinforce, these wide dynamic range neurons are really the key in the processes of getting allodynia and secondary hyperalgesia, because these wide dynamic range neurons not only receive signals from A delta and C fibers, but also from A beta fibers. So they end up covering way more dermatomes and increasing the receptive field from not only where the injury site was, but making that injury site bigger. And remember that Lesueur's tract, where that information relayed can either go up or down levels in the spinal cord, so now that pain you experienced at one dermatome level is multiplied across many dermatomes. On a quick side note, the NMDA receptor is a really good and unique receptor to know about. It's a ligand and voltage-gated cationic channel. In the resting state, it's in a closed state, which is blocked by a magnesium plug, and the activation requires 4 things to occur: glutamate to bind, glycine to bind, release of the magnesium plug, and then membrane depolarization. Ketamine is the main drug that we have that blocks the NMDA receptor, and remember, it's a non-competitive antagonist for the receptor. Finally, to finish this learning objective, we have a definition of few terms being preemptive and preventative analgesia. Now, I don't know how useful this is to know, but these terms actually have an important clinical basis. When you think about preemptive analgesia, what you're trying to do is provide analgesia before the nociceptors have been activated. So the classic example for this was looking at epidurals prior to surgery and seeing if this gives better pain relief than waiting for the noxious stimuli to occur and then giving analgesia. We know that this method works well. If you do a labor epidural for a woman before she starts having contraction, it does have good effect in preventing the contraction pain, but this type of analgesia doesn't work in all circumstances. Preventative analgesia is slightly different. It's looking at the properties of the effects of drugs in the post-operative period that exceed the expected duration of action of that drug. Now, right now, the ROCKET trial is occurring, and this is a good example of preventative analgesia. In the ROCKET trial, you're looking at the use of ketamine and having a ketamine infusion. The key endpoint with this is that you're looking at the patient 3 months, 6 months, 12 months down the track to see whether that use of the drug then was helpful in preventing chronic pain in the future. So while the drug is not having any effect at 6 months or 12 months, did it have long-term effects that lasted past the expected duration of when the drug stopped working? This finishes off a huge learning objective and takes us on to a few learning objectives which kind of overlap with each other. The first one of these we're going to cover is outline the mechanisms of progression from acute to chronic pain. Now, I've kind of already been mentioning the term chronic pain when we talked about peripheral and central sensitization, and you can see how those two important concepts overlap with chronic pain. In terms of putting some definitions to it, we say that acute pain is pain that usually lasts less than 3 months and is pain that is of recent onset and probably of limited duration, while subacute pain is pain between 3 to 6 months, and chronic pain is pain past 6 months or pain that persists after the initial pathological process has resolved. There may be no clear identifiable cause of chronic pain. It could be due to psychological factors, continuation of the pathology, spinal cord changes, neural injury, musculoskeletal deconditioning. But the key thing is, after the injury is resolved and you're still having pain, that's when you consider the patient has developed chronic pain. There's a really good BJA article which is titled Transition from Acute to Chronic Pain, which helps to clarify how this process occurs. And really what it states is that this process encompasses that peripheral and central sensitization. So in the periphery, you're getting the prolonged inflammatory process leading to that inflammatory soup that leads to a decrease in pain threshold, an upregulation of those receptors, and a change in the threshold of those receptors, leading to the process of peripheral sensitization. While in the spinal cord, the key players here are the NMDA receptors, the wide dynamic range neurons, and what they theorize is that initially when you have acute noxious stimuli, the NMDA receptors might be in a low active state. But as noxious stimuli continues, then you start to get these receptors being continuously activated. And this slow continuous depolarization leads to a cascade of secondary events that initially involve wind-up, but more so involve long-term potentiation. And that long-term potentiation is reinforced by a change in gene production, which leads to an increase in production of things like nitric oxide, which is implicated in both the induction and maintenance of chronic pain, the production of second messengers like phospholipases, IP3, DAG, protein kinase C, and all of these things are having a twofold effect. One, they're changing the neuroplasticity of that cell, and then they're changing the effects of the wide dynamic range neurons. Then finally in the brain, the sensory pain matrix that we described is also going through changes. There's a strong correlation between chronic pain and mental state, and you can see this when you look at risk factors for patients developing chronic pain. Classically, the risk factors have been low socioeconomic status, a history of mental health issues, injuries that are associated with workers' compensation. All these suggest that the limbic pathway is really important and the anterior cingulate in the development of chronic pain. So then naturally, how can you decrease that transition from acute to chronic pain? And again, that goes back to that initial diagram you have on your head of that person having an injury, say on the thumb, and that injury being transduced, transmitted, perceived, and modulated. If you think about it that way, you can stop the transition of acute pain to chronic pain by targeting analgesia at each one of these sites. In the peripheries, you can use agents like NSAIDs or local anesthetic. Within the spinal cord, you can use drugs or regional techniques. In the brain, you can use pharmacological and non-pharmacological therapy. And this is when we talk about the importance of psychology and mental state in the perception of pain. And we'll look at this in a lot more detail when we look at one of the past SAQs on this exact question. And going back to this LO, it links in nicely with one of the other LOs, which is outline the pathophysiology of neuropathic pain. We won't spend too much time on this because I think it's a topic that's more so covered in the Part 2 exam, but the basic pathophysiology of neuropathic pain revolves around pain that's caused by a lesion or a disease in the somatosensory nervous system. Now, this can either occur due to an iatrogenic injury, a traumatic injury, an inflammatory injury, or an infective injury, and the classic characteristics of neuropathic pain is the description of pain that's burning, shooting, stabbing, freezing, and is associated with dysthesis, i.e. abnormal sensation. The physiological processes that lead to the development of neuropathic pain involve an injury to the nerve, which then leads to ectopic firing of that nerve that is close to the dorsal root ganglion, and as that nerve starts to repair, it sprouts sympathetic nerve fibers that, along with the transected nerve fibers, begin to regenerate and then spontaneously discharge, leading to that transmission and the perception of pain. You can have different types of neuropathic pain, and classically they're divided into 3 different types. You can have peripheral neuropathic pain, where this is initiated by a pathology in the peripheral nervous system. Examples of this would be diabetic neuropathy, post-hepatic neuralgia, or an injured nerve. Then you can have central neuropathic pain, and an example for this would be post-stroke pain or spinal cord injury pain. Or you can have mixed peripheral and central neuropathic pain. Examples for this would include pain such as complex regional pain syndrome or phantom limb pain. The reason I don't want to spend too much time on this is that there's not been any SAQs asked on this specifically for the Part 1 exam, but it has been asked for the Part 2 exam, specifically looking at complex regional pain syndrome and phantom limb or post-amputation pain. This finally brings us on to our last learning objective for today, which has been a previous SAQ, and that is describe the alteration to physiology and perception of pain in the older patient. Now you can answer this learning objective in one sentence by understanding that pain perception in the elderly is altered by elderly patients having a higher pain threshold, however, a decrease in tolerance to intense pain and prolonged recovery from injury. If you were time poor, you could leave it at that, but if you want to understand why this occurs, you need to look at the peripheral and central nervous system individually. In the peripheral nervous system, there's a decrease in function and density of both the myelinated and unmyelinated peripheral nerve fibers. There is also a decrease in neuropeptides within this area. This means both transduction and transmission of pain signals is slowed down in the elderly. Within the central nervous system, there's sensory neuron degeneration and loss of myelin in both the dorsal horn of the spinal cord, affecting the ascending pathway, and then that same decrease in myelin affecting the descending pathway. What this again means is that the transmission of pain to the brain is decreased, as well as the intrinsic analgesic properties and the inhibitory pathways are slowed down. This is why we say that elderly patients have a higher tolerance to pain, because that pain conduction pathway is a lot slower. However, once that pain is activated, their normal descending pathway is also being compromised. Therefore, once they get pain, there's a higher risk for elderly patients to transition from acute pain to chronic pain. Complicating all this is that an elderly patient usually has coexisting disease, concurrent medications which increase the risk of drug interactions, changes that occur with both physiology and pharmacology, potential difficulties in assessing pain with higher risk of delirium, confusion and side effect of drugs, both analgesic and non-analgesic drugs. And then with the physiological changes, the classic signs and symptoms you see of someone being in pain, tachycardia, tachypnea, might also be reduced in an elderly patient. Therefore, your assessment of pain in these patients is also compromised. If you then think about how this impacts how we give elderly patients the best pain relief, going through it system-based, you know that the elderly patient has changes in body composition, liver function, kidney function, and cardiovascular function that all occur normally due to aging. Generally, there's an increase in body fat and a decrease in lean body mass. There's a decrease in liver size and hepatic blood flow. There's a decrease in kidney function, renal blood flow, and GFR. There's a decrease in cardiac output. And then within the central nervous system, there's loss of neurons known as redundancy. There's a decrease in nerve conduction. There's atrophy of the brain tissue itself. And there's more vulnerability of the brain to exogenous substances. All this means clinically is to increase safety in elderly patients. You give them analgesia slowly, you dose reduce them, you increase the duration interval between doses, and you pick drugs that have no active metabolites. What is the negative of all this? By going slow, sometimes you can undercook the analgesia the elderly need because you're worried about all the side effects. And this goes back to the crux of what we said. While the elderly have a higher pain threshold, when they do get pain, they experience higher pain and are at a higher risk of getting chronic pain. So you're on a constant battle of treating the pain appropriately without getting the side effects of the analgesia you're giving them. Which means that you need to try to use drugs that have the least side effects. Therefore, non-opioids like paracetamol, NSAIDs, regional techniques are better choice of agents to treat pain in the elderly population. Now there is one more LO that I've left, and that is outlining the prostaglandin pathway and the physiological role in the production of pain, but I think that's very self-explanatory, and the related concepts on Mac 95 cover it really well. The key thing I wanted to get through looking at all the LOs for pain physiology was making sure you understood that concept of that sensory pathway and how that sensory pathway relates to pain, transduction, transmission, perception, and modulation, knowing the key terms of peripheral and central sensitization, knowing that within these, the further key terms were inflammatory soup, wind-up, and long-term potentiation, and what those terms actually mean, and how they relate back to allodynia, primary hyperalgesia, and secondary hyperalgesia, and then understanding how these processes are key from the transition from acute to chronic pain. If you understand those things, I think you get what the curriculum is trying to convey to you with this topic. And this leads us on nicely to looking at the past SAQs on this topic. There aren't too many SAQs on pain physiology itself, but the SAQs that are asked seem to have a low pass rate. And the first one we're going to review is the most recently asked question back in 2023 first sitting, which was, describe the pain of the first and second stages of labour using the following headings: the causes and characteristics of pain, the anatomy of the primary afferent nerves and spinal segments involved. Now this is a repeat question asked also in 2017 where the pass rate was 20%, but when it was subsequently asked in 2023, the pass rate jumped up to 65%. Now the examiner report isn't very helpful for both of the times that this question was asked, but what it does do is that it clearly states in order to pass this question, you needed to target those headings that they've stated in the question. And that is really how I would base my model answer. My model answer would start off with a basic definition of pain types divided into visceral and somatic, where visceral is mainly from the C fibers and it's slow, it's dull, and it's poorly localized, while somatic is mainly carried by the A delta fibers, it's sharp, it's quick, and it's well localized. Then I would go into pain in the first stage of labor. I would define quickly what the first stage of labor is. So it's from the start of uterine contractions all the way till full cervical dilatation at 10 centimeters. And you can further divide the first stage into early and late stage. Then my first subheading here would be causes of pain, in which the main cause is a uterine contraction, leading to the characteristic of pain being visceral, dull, poorly localized pain. In terms of the anatomy, which is the next subheading of the primary afferent fibers, you would say this is piggybacked onto sympathetic nerves, and the main sympathetic nerves here would be your ovarian and your inferior hypogastric nerves. The spinal segments for these would range from T10 to L1, and you could divide this further and say that in early first stage, this would mainly be from T10 to T12, and in late first stage, this would be more from T12 down to L1. What that means is as first stage progresses, you might start with generalized abdomen pain, but then that pain goes down into the groin as the baby descends down. If you want to be really clinical here, you could say that pain would also vary depending on the position of the fetus's head. So an OP baby classically has that really excruciating back and sacral pain, which isn't as well covered with an epidural. Then in terms of the second stage, you would do the same thing again. You would define what the second stage is, which is the delivery of the baby. And here you would say that the characteristics of pain are a combination of both visceral and somatic pain. The somatic pain occurs through the pudendal nerves, which are S2 and S3, and the ilioinguinal and genitofemoral nerves as the baby is delivered out, as well as the stretching and the tearing of the perineum and the outer 1/3 of the vagina. The reason you get visceral pain associated with this is due to the increased stretch on nearby structures. So the structures that would be involved here would be things like the uterus and the bladder, and this visceral pain would again be carried by the inferior hypogastric nerves as well as the lower S2 to S4 sacral plexuses, giving you a combination of that localized pain but also that dull pain in and around the thigh. Then once you've finished off talking about the first and second stage of labor, I would then have a connecting statement to the ascending sensory pathways. And the main tract you talk about here is your spinothalamic tract. And really, you don't have to put anything extra apart from that, because in the examiner report specifically, they have said they haven't asked about the second order neurons. They've only asked about the primary afferent nerves. And so you could even omit this detail if you felt like it. And the simple clinical context to go with this is that this pathway can be easily blocked with an epidural. Now again, you can omit this part because the question isn't specifically asking about analgesic options. So if you wanted to be even more streamlined, you would just focus on those 4 headings of causes, characteristics, anatomy of the primary afferent nerves, and the spinal segments, and you could leave it at that. The next SAQ we're going to talk about is from 2021 first sitting, which was describe the peripheral and central nervous system pathways that lead to the perception of pain following a laceration to the thumb. This question is again a repeat question, and the first time it was asked had a 40% pass rate, but the second time it was asked had a 92% pass rate. Within the examiner report for this question, they broke it down into 6 major domains, the first one being a definition of pain, the second one being nociceptors and transduction, the third one being spinal cord synapse, the fourth one being ascending and supraspinal pathways, the fifth one being cortical processing, and the sixth one being descending modulation. You can see why people get so frustrated by examiner reports, because in this question, you could make the argument you aren't really asking about the descending modulation pathway, while in the previous question, if you were to talk about analgesic options, you wouldn't score any marks. So it's really hard to know when do you put in that extra information, or when do you stop yourself and just move on. Within this question, you could make the argument that the descending modulation pathway alters the perception of pain, and they haven't specifically said talk about the ascending sensory pathway. And I guess if you were an examiner, that's what you would look at in this question, and then that would be the way you justify why these are the 6 domains being assessed. Regardless of the technicalities, this question had a really high pass rate, and there's one thing in the examiner report which I think is really useful, and that is candidates who used a simple, well-labeled diagram were better able to organize their answers and ensure they addressed all the domains required. So I think if you get this question and you have that diagram of the person having an injury to the thumb, having that idea that pain needs to be first transduced, then transmitted, then you have perception, followed by modulation. You can think of modulation both in the ascending pathway and the descending pathway, but for me, I just put it at the end so I don't miss this out in my answer. And really, the model answer for this question encompasses everything we've touched on when we went through the LOs looking at the sensory pathway. Starting off with that new definition of pain, which is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. From there, you can just break this question down, starting off at the nociceptors and say there's multiple types of nociceptors, and we broadly classified them into C polymodal or A mechanoheat, and they're activated by a combination of stimuli that can either be mechanical, thermal, or chemical, remembering that they have a high threshold. From this, you have the primary afferent neurons, of which we have our A delta fibers and our C fibers, and they enter our spinal cord through our dorsal root, where they release neurotransmitters like glutamate and substance P, which then activate our secondary afferent pathways. And prior to that activation, the nerve roots can either ascend or descend through the Lesueur's tract, and they cross over straight away. Our ascending tract, our main one is our spinothalamic tract, and if you couldn't remember the other ones, I think that'd be okay, because that's the main one that we know of, that relays pain up to our 3rd and 4th order neurons. And that leads us nicely to then talking about the pain matrix, which is made up of the somatosensory cortex, the insula, the anterior cingulate, the limbic system, all having roles on how pain is perceived, how pain is memorized, and how pain is remembered and encoded with certain emotions. Following on, you have your descending pathway, of which there are 3 important ones: the paraaqueductal gray, the raphe nucleus magnus, and the locus coeruleus, all of which help to decrease the sensation or the transmission of that ascending pathway. The next question to look at is from 2016 first sitting, which was outline the physiological mechanisms of progression from acute to chronic pain and how drugs may alter this progression. This question overlaps a little bit with another question asked in 2014, which was describe the physiology of pain pathways and how drugs may modulate the perception of pain. That question had a 50% pass rate, but the question in 2016 had a 24% pass rate. I think what makes this question really hard is the fact that it's two different questions in one. There's the concept of how acute pain progresses to chronic pain, and then there's the concept of how drugs work to treat the pain and slow the progression. If I was a betting man, I would pick that this question is the most likely to be repeated again because of that low pass rate and because it has pretty important clinical significance. In our day-to-day practice, we really try to aggressively treat acute pain because we know it's the biggest risk factor for stopping chronic pain. In the examiner report, some key characteristics that they wanted you to mention or were shown in some really good answers were mentioning things like sensitization, wind-up, allodynia, hyperalgesia, phantom pain, and memory. The other important thing was that they gave you a template for how you could link these two separate parts of this question. And the way you could do that was talking about risk factors of chronic pain divided into patient factors, surgical factors, pain factors, and drug factors, and then use that as the basis to discuss the mechanism of drug actions to alter the progression of acute to chronic pain. So if I was coming up with a model answer for this question, because you only have 10 minutes, you really want to be spending only 4 to 6 minutes in that first section and probably leave less time, maybe 3 to 4 minutes for that second part, because you know the first part requires a little bit more explanation. To start this model answer, I would have a brief definition of acute and chronic pain. In terms of the physiological mechanisms, I would then say the two main factors that lead to progression is 1, peripheral sensitization, and 2, central sensitization. These can occur independently or in combination. With peripheral sensitization, the key word you want to write here is that inflammatory soup. So it's that buildup of those inflammatory mediators at the site of injury that leads to the development of primary hyperalgesia. And the reason is the inflammatory soup creates an alteration of those nociceptors that either decrease their threshold so that they fire off much more easier, or it leads to a lot more being activated with a stimuli. In contrast, with central sensitization, this is a central process, and the two key terms here are stating that you get allodynia and secondary hyperalgesia. The key processes driving this are a combination of wind-up and long-term potentiation. With wind-up, the main receptors here are your NMDA receptors, so repetitive activation leads to them having a lower threshold of activation as that NMDA receptor continues to get primed and activated. What it's then doing is altering gene expression and second messenger release, which is what's driving our long-term potentiation. Here, some genes to remember are our CFOS gene, and the CFOS gene, which encodes the CFOS protein, is an established marker for neuronal activity. So it's a key one to remember whenever you think about the term long-term potentiation and the NMDA receptor. From there, drugs can be targeted to alter the progression to chronic pain by either targeting patient factors, surgical factors, pain factors, or drug factors. So patient factors, you might think about psychosocial input, whether that's CBT therapy, the use of antidepressants or antipsychotics to improve mental health. You could also mention other patient factors like sex, genetic predisposition, socioeconomic factors, but all these don't really have a drug you could say that can alter these factors, so it's kind of a moot point. And whether you want to omit this from your answer just to save on time, I think that would be reasonable. Then when you talk about surgical factors, you could talk about the use of local anesthetics at wound sites, adjuncts of regional anesthetics, different surgical techniques, i.e. laparoscopic versus open. And again, while that's not a per se drug factor, I think it is an important factor. And then the type of surgery itself. And we know that there's some surgeries that are high risk, such as cardiac, thoracic, any surgery where you're getting an amputation, whether that's a BKA, a mastectomy, all these surgeries are high risk. So in order to link this to how drugs may alter the progression, you might say in these situations, you'd rely heavily on regional and local anesthetic techniques. Then you have the pain factors, which I think is the easiest one to cover, because here you just talk about treating pain using the WHO ladder. The last factor is drug factors, and really in my head when you think about drugs that helps to prevent chronic pain, there's two drugs I think of: ketamine and local anesthetics used for regional techniques. Yes, there are other drugs that are helpful in certain situations, such as for neuropathic pain, your gabapentin, your pregabalin, your tramadol, your TCAs, all that is important, but I think you can't miss talking about ketamine and you can't miss talking about local anesthetics. You can see, even in my attempt to make a model answer, it's a really complex question and it doesn't have a straightforward template for a model answer. If you don't like using the risk factor approach, the other approach to thinking about drugs would be to go back to that diagram of that patient having the injury from the thumb and that pathway ascending and descending. And I think if I was doing this question under time pressure, that's probably the one that my brain would go back to then cover the second part of this question. The last question we have for today was asked in 2014, which was describe the alteration to the physiology of the nervous system in the older patient and outline the consequent effects on pain perception. This is a question that had a pass rate at 16%, making it a very high risk to be asked again. And you could justify this question being asked again because we know that the population is aging. In the examiner report, the examiners recognized this was a relatively difficult question, and for this, they gave a huge degree of slack on how the question was answered. And we've already kind of touched on a model answer for this. Again, if you break it down into that picture of the pain, transduction, transmission, perception, and modulation, and how these pathways alter with aging, I don't think you'll have any issue answering this question. You can say that in the peripheral nervous system, you generally have a decrease in your speed of your primary afferents. You may have a loss of neurons, a loss of axons, a loss of neurotransmitters that compound that slow speed of those primary afferents. And then when you get into the central nervous system, you again have a slow ascending tract which has gone through some demyelination. You have a loss of central processing power because of general brain atrophy that comes with aging, associated with a decrease in grey matter, white matter, and neurotransmitters again. What that means is that the descending pathway is also affected in the same way, leading to them having a higher experience of acute pain and a higher incidence of getting chronic pain. Compounding all this, and I think you'd put this as an adjunct, is that the elderly have a higher risk of polypharmacy drug use, a higher incidence of having side effects from analgesia, especially opioids. This can lead to a higher incidence of delirium, which can alter the way the pain is assessed in the elderly, leading to an under-recognition of acute pain. You have changes in key body organs, which lead to a high accumulation of active metabolites, all of which means you need to have unique ways to assess pain in the elderly, and you want to try to use options that give the least side effects. So with that finally brings us to the end of this episode. It's a really hard topic to get your head around, a lot of concepts that overlap, but if you can go back to that diagram in your head of the person having an injury from a peripheral or distant site, that injury being transduced, transmitted to the spinal cord where it gets perceived in the brain and then modulated, and you know the steps involved for each one of these processes, you can then apply that knowledge to answer questions, and it should be the one thing you take away from this episode. This also means we've come to the end of our neurophysiology and pain series, and I know that the second sitting for this year is coming up rapidly, so I just want to say best of luck to everyone sitting, and I'll catch you guys next time on Count to 10.